Hi, this is Ali Jazayeri. I'm a cardiovascular disease fellow at University of Kansas in Kansas City, and I'm joined today by Professor Tracy Wang, who is a cardiologist and associate professor of medicine at the Duke Clinical Research Institute, and is presenting the findings of the ARTEMIS trial here at ACC. Welcome, Dr. Wang.
Thank you. Thanks for having me here.
So I wonder if you can start off by giving us an overview of sort of the rationale for this trial and what you were hoping to accomplish.
Great. So we know what guidelines recommend for post-MI patients. We know that guidelines say we should use dual antiplatelet therapy for a year. And we also know that guidelines tell us that we should try to use higher potency P2Y12 inhibitors where possible. But if we confront the reality in the United States, we see that clopidogrel is still the most commonly prescribed medication, and that many of our patients don't make it out to 1 year on dual antiplatelet therapy. And as a physician, you know that a lot of it is we listen to our patients and our patients tell us, I can't afford it. So that's a reason for both of these things. So we designed this trial to say if we took cost out of the equation, would that allow us as physicians to do a better job prescribing evidence-based therapy? Would that allow our patients to be able to stick to treatment longer? And at the end of the day, does it help patients do better? So that's really the background of this particular trial.
Very interesting. And how did you go about designing the study to make sure that you were able to appropriately answer this question?
So first of all, we needed a good sample size to be able to answer this because we did want to try to get to all of these questions. The second was trying to decide between a patient randomization versus a cluster randomization. So we actually chose to do a hospital randomization. And the reason for that is because if we did that, then we can actually study physician behavior as well as patient, individual patient types of questions. And that was really, really important to us. So we implemented this on a hospital level. So out of our 301 hospitals, some were randomized into the copayment intervention arm, and some were randomized into the usual care arm. In both of these arms, clinicians had entirely their own say about what to use and how long to treat for. The study protocol had nothing to do with that. It didn't say you needed to use drug X or drug Y. It didn't say you need to treat for 12 months. It just said, you as a doctor, you know your patient, you need to do what you think is right for the patient. But in the intervention arm, we were able to give the patients a copayment voucher that made the price of clopidogrel the same as the price of ticagrelor, and even better, their out-of-pocket costs were $0. So that was really how the intervention was set up. And so this allowed us to really get at those three questions we were trying to answer.
Now, there's one question obviously about whether physicians are prescribing the medication and whether the cost is appropriate or feasible for the patient. The other question is once the patient has successfully obtained the medication, are they adherent to it? And how did you go about making sure that was the case in this trial?
So I think what you're getting at is that we are worried that our patients may be overly optimistic about their medication taking behavior. And that was something that occurred to us as well. So we assessed medication persistence in a number of ways. First, we asked the patient, are they taking this medication? Have they had any gaps in treatment? That was one way. The second way was to actually link the patients to their pharmacy fill records so we can go and see if they were actually picking the medication up from the pharmacy. But a skeptic might say, well, they could fill the medication and just stockpile it at home. So a third way we measured this was in a subset of patients, we randomly selected them to go get a blood draw, and then we tested the blood to see if there was any drug metabolite there.
That's a very rigorous assessment of
we think so.
Treatment adherence. And so would you mind summarizing briefly about what the main results of the trial were?
Yes, so the copayment intervention worked in that it did change physician prescribing behavior. So we saw 18.7% less clopidogrel use, which means that once you took the copay out of the equation, clinicians felt like they were able to use those higher potency P2Y12 inhibitors as guideline might recommend that they do. So that was the first hypothesis that was proven. The second was we did show that patients were able to stick to therapies longer. So we characterized this in terms of that non-persistence. And it didn't matter which method we used to measure it, the intervention arm did better than the usual care arm, on the order of anywhere between 16 to 35% better, depending on what measurement you chose to look at. At the end of the day, though, we were a little surprised to see that there was no difference in clinical outcomes. And so as we probed that, we found that, and this was a pre-specified analysis, we found that 28% of the intervention arm patients didn't use the voucher. And we were trying to understand that a little bit, but if you reran the primary endpoints in the as-treated group versus the usual care group, now we see again a significant difference in medication persistence, and we start to see the curves diverge a little bit on the MACE side of things. We are always underpowered for an as-treated type of comparison. And of course, in this type of secondary analyses, we have to be a little cautious about how we interpret those results, because the patient who's motivated to use a voucher is probably motivated for other things as well. But it was interesting that the intervention arm patients who never used the voucher happened to be the ones who had the highest risk of MACE and the highest rate of non-persistence. So what that tells us is copayment reduction as an intervention works, but if we really want to make an impact on clinical outcomes, then we probably need to think about putting the copayment reduction in the setting of a multi-pronged strategy to really target adherence, so that we can really get a good amount of improvement adherence that leads to clinical outcomes improvement.
Very interesting. Thank you for sharing that. And I have a question related more to fellows in training, and I know you have a great interest in outcomes research and identifying disparities, and sort of a newer area of investigation is implementation science. I wonder if you could give a little bit of an overview on what that is and how you define it for those who may be interested in pursuing that.
Well, I remember as a fellow coming to this meeting and just being floored by all the science that was being presented. And I think every young investigator sort of starts out with that grand dream of being the next person on the stage talking about this new therapeutic. But, as I continued to practice, I think I started to get a little bit more frustrated to say, hey, we've got this great science, these novel therapeutics, but they're not being translated as quickly into practice or as perfectly into practice. So in a way, it's almost, what's the use of coming up with this new science if we're not going to implement it quickly into practice? And I think that's where I've focused my energies over the last several years, is to say, we really need to do a better job of doing this. And implementation science is a relatively new branch of it, but it's really focused on applying rigorous research methods to different types of interventions that can help us get that research into practice a little bit more efficiently. And I would highly encourage any young investigator to think about this, as well as, the doing the new science part, to be able to say, get some great satisfaction from their research career, and that it really ties into, clinical practice.
Absolutely. Thank you very much for your time, Dr. Wang. This is Ali Jazayeri from University of Kansas. For more videos like this, go to www.youtube.com/FITsontheGO.